Welcome to the Teaching Value in Healthcare Learning Network. Join us to hear leaders in the field share practical and tangible advice about how to develop engaging curriculum and health system innovation to train a new generation of healthcare providers from diverse specialties and professions skilled to deliver high-value care. With national concerns about rising healthcare costs, as well as overuse, underuse, and misuse of medical care, CASA Care and the ACP-AAIM Foundation created the Learning Network as a space to share ideas, educational materials, and strategies in an open forum. Our goal is to discuss ways to get started, implemented, and sustain feasible innovations in teaching value at your institutions. The Teaching Value in Healthcare Learning Network will have three major components: monthly webinars, 30-minute sessions to hear on-the-ground and national leaders share successful innovations with a focus on how to adopt them at your own institutions. Sessions will be held on the third Thursday of every month, as we're doing today. Discussion groups in an online forum to facilitate getting advice on how to launch new innovations. We hope to help each other troubleshoot any challenges that may arise. And tools for educators, which is a space to store materials needed for dissemination of curriculum shared by educators from across the country and Canada. We already have a number of tools available for you now, and will continue to add more over time. You can find this link on the left side of the Learning Network website. I am Chris Moriades, a hospitalist at UCSF, Director of the UCSF Caring Wisely program, and Director of Implementation for CASA Care. I will be moderating today's webinar. Today we are honored to have Dr. Cynthia Daisy Smith join us. Dr. Smith is a practicing general internist with the University of Pennsylvania and the Director of Clinical Program Development at the American College of Physicians. She also has helped organize a high-profile event at the National ACP Conference on April 30th to showcase the winners of our Teaching Value and Choosing Wisely Challenge. Today she'll share insights about implementing the ACP-AAIM curricula on high-value care and other efforts led by the ACP to teach medical students, residents, faculty, and practicing physicians. We would like to make the session an interactive discussion and ask participants to submit questions online. We're looking forward to a great discussion. So Daisy, I'll let you take it away.
Thanks, Chris, for that kind introduction, and good afternoon, everybody. So I was going to just start by giving you some idea of the things that ACP's done so far to help faculty teach high-value care. First of all, as Chris mentioned, we collaborated with the Alliance for Academic Internal Medicine and got program directors, faculty, and even some residents to help develop the high-value care curriculum for internal medicine residents. And that is freely available on our website, the link to which you have in one of the tools. In addition to creating the curriculum, we also have created a high-value care subscore on the internal medicine in-training examination. So when residents get their scores back and programs get their scores back from that exam, they also get, in addition to getting a score in cardiology, they will get a score in high-value care. So that's a way of sort of baking it more into the educational milieu of residency programs. In addition, we took the materials and the cases that we created with AIM and put them in a web-based platform for practicing clinicians, and those are available as online high-value care cases for practicing clinicians, also free on our website for MOC and CME, and actually now CE credit for nurse practitioners. And we did a collaboration with MedU to bring these materials and cases to medical students, which are freely available on the medu.org website, and we had some funding from the ACP-AAIM Foundation to help with that. We've done a series of faculty development workshops at national and regional meetings, but I think one of the biggest things, we've done a lot of these standalone things around high-value care, is that we've had a really integrative approach at the college to integrating the concept of high-value care and practicing high-value care into all our educational programs. So our medical knowledge self-assessment program, otherwise known as MICSAP, that people use to study for the internal medicine cert and do MOC, has high-value care call-outs, high-value care questions. You can get a sub-score. On MICSAP 17, you'll be able to get a high-value care sub-score. Every session at our national meeting every year has high-value care learning objectives. As I said, we have incorporated into the in-training exam. We have an abstract and poster competition, publications and annals. So this integrative approach has also worked really well. I would say more people have learned about the curriculum and high-value care. They've learned about high-value care through MixApp than they have through the curriculum. So those are some of the things that we've done so far. I know, Chris, you wanted me to mention how folks are using this, so I'll talk a little bit. In internal medicine residency programs, the curriculum as it stands now, when we initially launched it, it was 10 one-hour sessions. We relaunched a revised version in 2014, and we narrowed it down to 6 sessions. So those 6 one-hour sessions have been put in noon conference. They've also been incorporated into morning report, pre-clinic conference. A lot of programs have gotten a small cadre of faculty, either hospitalist faculty or ambulatory faculty, to really get up to speed on the content and teach it. I'm trying to think about what else. Oh, the ambulatory block rotations are another place where this content is getting delivered. In terms of the student cases, there are places we're actually studying the online MedU student cases in 4 different medical centers and during the 3rd-year clerkship. So we're requiring students to do those cases and then seeing if that makes a difference in their attitudes towards high-value care and also their knowledge of high-value care concepts. But some programs have done a more integrated approach within their program. So in terms of having morbidity and mortality conference, grand rounds, all their conferences having some high-value care component to it. And I think those are sort of all the things. I don't know, Chris, if you have any other, if you're aware of any other ways or examples of how folks are applying the tools that we have.
No, I think that's fantastic. I think what's so impressive is how you and the ACP have really integrated this into all aspects. You know, the education, providing the education, which, as you know, is necessary but likely insufficient to really drive change. And yet, so then you bring the responsibility and the accountability, baking it into the tests, into MixApp, and the high-value care subscore. And so I think that's what's really interesting, because many of us could give a lecture or put together a PowerPoint, but to really put together an integrated curriculum and then use the sort of platform of the ACP to make it part of the high-stakes exams and really make people accountable. I guess my question for you, Daisy, is your sense? My sense has been that when you put out this curriculum, the excitement actually kind of came organically from the ground up. That there were chief residents or young faculty members or folks that wanted to teach this and were using the tool and taking it on, rather than, say, program directors or other people saying, oh, shoot, we have to, you know, address high-value care. I need someone to teach this. Has that been your experience, that the champions on the ground have been really uptaking this and running with it? Or have you, from your position, seen more of kind of a regulatory stance to it?
Oh, no, absolutely. I think your perception is correct. Because this isn't really, though high-value care is woven into some of the internal medicine milestones, it's certainly not a standalone competency the way it is, and the ACGME hasn't taken it on as such, so it's not really a top-down, it's much more of a bottom-up. When we launched it, and this was one of, I outlined some lessons learned for those of you who want to go out and develop your things, but the one thing I would say is, we're really surprised. It's been downloaded over 32,000 times since it was launched. And when we look at who's downloading the materials, a lot of learners are downloading the materials. I'd say about 1/3 of the folks who are downloading the slide decks and the facilitators' guides are students and residents. And the informal feedback that I get from program directors is they can't get the residents out of they love talking about this stuff and they're really interested and engaged, and it's sort of captured their imagination. The last hour of the curriculum is focused on getting residents and faculty to work together on high-value quality improvement projects. So I also think that active piece of the curriculum really helps engage both programs and residents. And we've been tracking, not exactly, but through survey the number of projects, and last year at this time we had 120 high-value quality improvement projects, and I just looked at the data from October, and we have over 350 high-value quality improvement projects. So those are really sort of a groundswell. And to me, everyone always said curriculum doesn't change behavior, but I think these projects show that it actually can. It's certainly not sufficient, but it's a start, and you got to start somewhere.
Yeah, absolutely. And I think, you know, setting the why people should care about this, and setting that up, and then giving them a little bit of the how to do it is really how you're changing the behavior. And it's exciting that people are taking it up and kind of running with it. But I suppose that brings up another challenge, which is, you know, myself, I became interested in this as a resident and wanted to start teaching it. And as you're saying, there's lots of learners that are now picking this up, but they don't necessarily have the faculty mentorship to help them with this, since their faculty didn't learn this during their own time. So I know that you've also taken on an important role of faculty development and teaching others. And so maybe you could tell us a little bit about that work.
Yeah, well, we recently surveyed program directors to try to get a sense of how many of them actually knew about the curriculum and how many were using it. Unfortunately, we only had about a 55% response rate on the survey, but 4 out of 5 programs were aware of the curriculum, and of those folks who were aware, about 83% were using some portion of it, which makes about 150 programs. So it's about half, or a little less than half. But again, our response rate isn't great, so I would imagine it's a little bit higher than that. But when we asked them why those folks who knew about the curriculum and weren't using it, the answers were interesting. One was that they weren't using our curriculum because they had their own, so that was about a third of the folks. But second was no faculty to teach it. So I think that's one place where I feel like we really need to do a better job in faculty development, and one of the reasons why we developed the online high-value care cases is because we thought that was a really nice faculty development tool. You could go online, you could do the cases, get your MOC, get CME credit, but also prep yourself to teach the curriculum that way. But we're also doing a series of live faculty development one-day workshops, in addition to a lot of the work that we've done traversing the country, both you and I, right, Chris? Doing grand rounds and GME faculty development. But this is, we're doing one at ACP, probably late spring of 2016, and there will be one in conjunction with the APTM meeting also in the spring and in the fall. So we have 3 that we've committed to one-day meetings where we can pull from all over. The ACP meeting is going to be interesting because we're actually going to pull from, we're going to invite teams from hospitals to come so that we can get some folks from the C-suite and hospital administration to come too, because it seems like that's where the catalyst for a lot of change. So right now it's been bottom up. You definitely need to get those folks on board. And I know, Chris, you've been really successful at UCSF in getting your C-suite behind this project.
Well, I've been very lucky at UCSF by having my C-suite behind this project. So I think I totally agree with you. And in my experience, you know, I've called it the support spine, which is if you look at the organizational chart, you can have someone like me sitting on the bottom, but as long as you've got a direct vertical line up the organizational chart of support. So that means at the department chair level, you know, Dr. Talmadge King here, all that really takes is for him to say, yes, choosing wisely is a priority, and I support what Chris is doing. And all of a sudden I have the agency to go do that. And so I've argued that you don't even need it necessarily across organization horizontally. So perhaps, you know, another division or department within our medical center is not ready to take this on, but as long as within sort of a single line, I think that's really helpful. I want to remind our folks that are listening live that if you type a question in the question box, we're watching that, and so we'll be able to share your questions as they come. My question for you, Daisy, you mentioned about how one of the reasons folks haven't used the curriculum is for is because they have their own curriculum. And I know that had been my experience, and I assume maybe a lot of the people listening right now are high-value care champions and have their own sort of curriculum or things they've done. And what I have found was that one of the real strategy, or one of the real strengths of the ACP curriculum is that you can take pieces of it and you can take parts from one lecture, or take a specific video, or take a specific small group project and integrate that into whatever you're doing. And so I don't know if my advice tends to be take what you can from this, and you can pick and part it if you want, or take it as a whole, if that's the case. I don't know how you feel about that strategy.
Well, actually, that was exactly what we had intended when we created it. The materials are copyrighted, but the copyright is extremely loose, so anyone can take what we've done and repurpose it, alter it, and use it for educational purposes. You just can't sell it. That's the only limitation. So it's an incredibly loose copyright, with the idea that folks like Suzanne Woods and Carolyn Avery from Duke, they took it and plugged in all pediatric cases and made it a pediatric curriculum. So that's now available on the MedEd portal. And we're taking pieces of the curriculum now and adapting it for subspecialty fellows. And that's essentially what we did when we created stuff for the students. But I love your idea, Chris, of taking pieces of it, because you really want to make it, so much of this is cultural, that you want to instill the culture of the medical center or the institution where you're working into the presentation, so it has face validity and people get engaged in the material.
Yeah, thank you. Yeah, and that's what I've done actually with, I have a monthly curriculum that I give here, but I took the the ACP curriculum on barriers and mixed that in with what I was talking about that day, and so it's really a great resource, I think, for learners. So we have a couple questions here. Reshma says, thank you for sharing the curriculum. I'd love to hear about any challenges that you've heard folks having getting and broadly implementing at institutions, and how do you suggest troubleshooting this? And a similar question for Vinny is talking about strategies to use with faculty that are resistant or worried that we're focusing too much on cost of care. So maybe you can, those both sort of overlap here.
Right. I mean, I think one of the big issues, I said the third barrier is that the curriculum is too crowded. So I think there are a lot of external mandates, and programs and program directors feel pretty overwhelmed with the amount of content they have to teach, and now they have to do QI. And so again, what we've tried to do is make it a twofer. So if you do the high value care project, that's why we call it a high value care QI project, because then you can sort of incorporate it together, and that's why we took what we had initially developed as 10 sessions and put it down to 6. I think the biggest institutional issue that program directors have had in terms of institutional buy-in is really getting cost transparency. So it's very, very difficult for, one of the things we did when we did the case with the inpatient versus the outpatient DVT is initially when we developed it, we didn't provide the bill. We charged the faculty with going to the billing department at their hospital and getting bills for 2 similar cases. And they basically came back and said, you need to provide us with the bills because we can't get access to the bills. So I think it is very difficult to get finance on board. And I have to say that I personally haven't been that successful, though I do think it really depends on your hospital system. Now at Penn, they actually are on board, but at Lankenau Medical Center, where I worked before, I was never able to get them. So I think it depends how the payment structure works in your hospital and how incentivized the hospital is to try to save money and to get their providers to be cost sensitive. So I think that is shifting with ACOs, DRG payments, that kind of stuff. So I think that the C-suites are rapidly coming on board, but that is at least historically the thing that people have complained about most. I think the other thing is, though, you talked about the spine, that you can go up through your department, but more and more I think a siloed approach to this is not nearly as effective as getting everyone in GME on board and pulling in other specialties like emergency medicine, because what happens is if you just have one silo in a room, they have a tendency to attribute a lot of the waste to other providers that are not themselves. So you kind of have to redirect and say, okay, well, what's under your control? It can't all be the ER. Or the emergency medicine folks, and it's just a much richer and really honestly a much better discussion when everybody's in the room, because in the end it's all about communication and getting providers to communicate better with one another and set expectations and also communicate better with patients.
Yeah, I completely agree. Thank you for clarifying what I was saying, which was mostly just to say that you can start within your own group and then it starts to grow organically and clearly trying to get everybody in the boat is really important. So I appreciate that. And I also remember clearly the lesson of when we told people to go out and get hospital bills and
Yeah,
immediately
they
found
said
out how
no.
challenging that was. So we have a great question here from Jimmy Beck, who's up at Seattle Children's, who's asking, how do you think we can measure the efficacy of these interventions in curriculum? I know that's something Jimmy's actually been thinking about a lot. In fact, I have a much overdue email response, Jimmy. It will come to you soon. I'm sorry. But at any rate, how do you think, Daisy, we can measure the efficacy of these interventions?
Yeah, it's always hard to measure the efficacy of curricular interventions. I mean, I have to say I mean, Reshma's and you guys are working on the culture survey, which I think would be interesting to be able to track how your institution does with that on high value care culture over time. You can track knowledge, though. That was one of the ideas behind developing the internal medicine, the in-training exam high value care subscore, was to be able to track to see whether those scores went up, or programs with a low score, whether they did some sort of intervention. We have been tracking the number of high value quality improvement projects because I feel like that's a real metric, but it's much easier certainly to follow that at your own institution. There's a number of attitude surveys. We did develop an attitude survey for the medical student project, which has been validated, so you can see whether your learners' attitudes are changing as well. But I mean, as we all know, since we're medical educators, measuring the efficacy of an educational intervention can be really hard to do.
Great, and so we're getting a few more questions in here. So Kim Tartaglia asks, I think we've touched on this a little bit, but maybe, she says that she's really appreciated the ability to modify and combine the modules to fit their institutional needs, which we've talked about. One area that she struggles with is that although residents are very interested in talking about this, she hasn't quite seen resident practices change yet. So thoughts about that, and that, how can we really move this from talking to doing?
Yeah, that's a really excellent question, because I have to say when I do talk about this, I always say we need to move this now. The curricular materials are great for starting the conversation, but we really need to move it from the conference room to the patient's bedside, or into the examination room. And I think that's part of faculty development. So you need faculty who are going to role model this, who are going to bring it up on rounds, who are going to champion it. And I think you also need maybe some forced functions. One of our winners is of the Teaching Value Challenge, who's going to be presenting, created a SOAP V, which is when medical students are presenting on rounds, they present their subjective objective assessment plan, and then they have to have a value part of their presentation and also about their note. But doing something where it's a forced function and it's really built into the patient care, or even, okay, you want to order this test, always, well, how is this test going to change what you're going to do for the patient? And really asking those questions on a more regular basis, and role modeling high-value care discussions with patients at the bedside. Part of the problem with that is that so much of our rounding doesn't happen at the bedside now,
Right.
but that's a whole other problem.
Right. No, I totally agree, and I found that with the curriculum, you have specific concrete lessons that come out of some of them. So do this, don't do this, and really just changing a small behavior. I believe, at least, and I think I've seen anecdotally around here, that starts changing the way people practice. So here we focused on a lab test called ionized calcium, and it's a silly lab test. But once we did that, I truly believe that we saw people begin to think differently about how they order labs in general. And over just 2 short years, we went from everybody being resistant to trying to tackle labs, which is when I first came into my job. I said, okay, we're going to get rid of the daily CBC, and everybody revolted and was saying, no, you can't do that. We started focusing on ionized calcium. Nobody had war stories about that. We were able to decrease it, and now just 2 years later, we have a project that was led by the residents that they came up with themselves called Think Twice, Stick Once, and it's all focused on decreasing phlebotomy. And so I really think it's that progression of you just got to find those easy early wins to really start changing behavior.
Yeah, and brought up the whole resistance piece, which I think is something that Vinny texted into one of these questions, and I don't think I answered that, but I think to get the resistant folks on the bus, you may not be able to get everybody on the bus, and that's okay, but it seems the cost frame does not work with very well with providers or patients, frankly, unless you're talking about what patients are paying out of pocket, because there is a lot more cost sensitivity there, for sure, but I don't think we have the tools necessary to really tell patients exactly what their out-of-pocket costs are going to be yet. But in terms of provider resistance, I find that the harms from overuse and overdiagnosis, talking about this in terms of decreasing harms and improving outcomes, that is the way you get them on the bus. And I think a lot about making medicine fun again. You know, we're not just test orderers, we're diagnosticians and clinicians, and if you can bring the fun back in it, I think it goes a long way.
Yeah, I agree. And you know, we had a great presentation last month from Rob Fogarty from Yale, who created the eye care curriculum, which is all about making it fun for, you know, residents to do this and to compete against each other and really bring back to, you know, how can I come up with the diagnosis with using the least necessary resources, and, you know, kind of brings back that I agree that fun part of this, as you said. So we actually only have a few more minutes. We have a few more questions here. So Neil is saying that he knows many other specialties, including his own, OBGYN, have been very inspired by the ACP curriculum. Going forward, what opportunities do you see to translate the lessons you've learned at ACP to other specialties?
Well, I guess I did outline some lessons learned. So I would say for other specialties, definitely you need to know the political landscape. We started getting into the surgical landscape, and Chris knows this well because I think he was on some of those uncomfortable conference calls, without really understanding the political outline. I mean, every specialty is different. So I would say before you get too far into doing anything, you want to make sure. So one thing is developing the materials is actually the easy part. It's getting people to disseminate them, promote them, and actually use them, which is much, much harder than I had realized. And it was nice with the curriculum because it happened organically. With the online cases, we haven't had as much use as we would have liked. And I think it is, so have a strategy for how you're going to do that. In order to do that, you have to get your specialty societies and the powers that be behind promoting it. That grassroots alone doesn't really work. I mean, you can try that, but I think you're going to need to get your professional societies on board. And a lot of them won't endorse your materials unless they're involved in developing them. So that's why I would say know your political landscape, and if you don't get to know it, figure it out, and then get a dissemination and promotional strategy around it too. And then I think we talked about this all, but try to figure out what's your step beyond the curriculum, how you can bake it into clinical practice. That curriculum is really just the starting of the conversation. And then don't forget about faculty development. I think that's one lesson that we were probably a little bit too late to the game on faculty development with this. You know, if I were to do it again, I would have rolled out a more robust faculty development up front.
It's fantastic. So we're coming up at the end of the half hour already. I know that there are still a question or two that we didn't get to, and I'm sure there will be many more as people view this video offline. And so I know that Daisy and I would be happy to field those questions, and we'll be responding to them on the Learning Network. Daisy, maybe, you know, we had briefly mentioned the ACP event and the Teaching Value Challenge and Teaching Value and Choosing Wisely Challenge Champions event. Maybe you can briefly talk about what that's going to be at the National ACP Conference.
Sure, yeah, so this is, so our centennial national meeting is going to be in Boston, and this event is on Thursday, April 30th at 11:15. It's right after our opening ceremonies where Tom Daschle is speaking, and this is the first time we've ever done this kind of format for an event, so it's going to be a TED-style event where the 4 winners of our Teaching Value or the Teaching Value Choosing Wisely campaign will be doing short TED Talks about what their innovation was that won the award. And then we have Lisa Sanders from the New York Times and Sandeep Juhar, who are going to be a reactor panel asking questions and talking about it. And it's going to be just a really, first of all, it's going to be a really unique format, and it's just a great way to celebrate these folks who are doing some incredible work and really inspiring. And we picked these winners were picked partly because we thought their projects were scalable. So, so if you want some good ideas, if you can't come, there is a one-day registration, so you can come and hear Tom Daschle. If you're a student on this, you can come for free. You just need to register online, and it's a 90-minute event. But then there will be high-quality video capture. So definitely, we'll try to figure out how we can host these videos here as well as on the ACP website, so you guys can watch them later.
Thank you so much. I think obviously that's going to be a fantastic event. So thank you, Daisy, for joining us today, and all of you for joining for a great discussion. Remember to check out the Tools for Educators link off the main page on the left side that will link you to some of Dr. Smith's publications and other materials needed to use these resources at your institutions. Also, we'd like this community to be yours, so please help us tailor it for you by completing a 2-minute survey that you find posted on the Learning Network discussion board. We invite you all to join us again next month on Thursday, May 21st, when we will have Dr. Mitesh Patel discussing the use of computer decision support. Also, if you will be at the National ACP Conference later this month, please join our session on April 30th and make sure that you say hi to our team. We'd love to put some pictures up on the Learning Network. So thank you all, thank you, Daisy, and we'll see you next month.
All right, thanks, Chris. Bye, everybody.